Thank you, everyone, for joining us for this EU-JAMRAI meeting. Really excited to have Dr. Qasim Alel here. He's a senior research associate from Nuffield Department of Primary Care Health Services at the University of Oxford in the United Kingdom. He's done a very interesting study. I think you're all going to be very interested by this study. And so turn the floor over to you, Qasim.
Thank you so much for that. Yeah, can you hear me well just before kicking off?
Perfectly.
That's great. Thank you. Well, welcome everyone. So my name is Qasim. Yeah, I work at the University of Oxford, and today we're going to go with this presentation. It's going to maybe last for a bit less than 30 minutes, but I think that's going to be perfect then for having a Q&A session. So the title of the presentation is Global Pricing of Key AWaRe, Access, Watch and Reserve Antibiotics. We are going to look into the implications of the UNGA, United Nations General Assembly, AMR 70% access target on national pharmaceutical expenditure. So I think before proceeding, I think we can first of all define what's the AWaRe book. The AWaRe book is basically a book. It was organized and designed by the WHO with several colleagues. And then in the AWaRe book, they classify antibiotics across 3 different categories. So the access, which is the green one, the watch, which is the yellow, and then the reserve one, which is the red category. Importantly, for access antibiotics, we find in there antibiotics such as amoxicillin, so basically the ones having less resistance risks. But then for watch and reserve antibiotics, we find antibiotics that are a bit more complex. They have more, they're more toxic for human health, and therefore they need to be used as last resort antibiotics, particularly for reserve antibiotics. So in this case, for reserve, we find cases like linezolid and others. So basically last resort antibiotics. So in the AWaRe book, they define different populations, such as adults and children, and they have different infection syndromes, as you can see it in here. For example, we have got pharyngitis here, and then according to the severity of the symptoms, the AWaRe book basically define what would be the appropriate treatment for treating these infection syndromes, and what should be chosen as the first choice, which normally is going to be an access antibiotic, and also as a second choice. And in the case that this is severe, or maybe there is potential for resistant risks, so perhaps they're going to opt for watch antibiotics in this case. So this is what the whole AWaRe, let's say, book is about, and this is what the AWaRe system basically underpins. All right, so, but importantly, and in 2024, by the end of the year, in New York, it happened, the United Nations General Assembly, and basically they had several targets, and one of the most important ones, let's say, was to set a 70% access target across overall antibiotic usage in humans. And this was set in this year and should be basically targeted by 2030. So in this study, basically we wanted to first of all, use the AWaRe framework in order to assess antibiotic prices across regions, across different antibiotic types, across income groups, and also to assess the affordability and price differences to improve access, reduce AMR potentially, and align with SDGs goals. And something important here is that we wanted to look into the shares of antibiotic usage. So, for example, what's the access percentage across different countries worldwide, and what's going to happen in terms of cost savings if they manage to match the 70% access target following the United Nations General Assembly. So, in terms of the data, this is a retrospective study. It's also an ecological study, so at the country level. We used antibiotic use at the country level, and also we had prices for different antibiotics using 2019 data. The data came from the IQVIA-MIDAS database, and in the case of prices, we took ex-manufacturer national prices across two different sectors, so the retail and hospital sectors. We cover in total 73 countries, representing more or less all WHO regions and World Bank income groups. We have got some limitations here, of course, because for the Africa region, for example, we only had, well, 2 countries in total. And then, of course, for very low income countries, we couldn't represent them that much, but only upper middle income and lower middle income countries primarily. Well, in terms of method, well, first of all, we wanted to measure AMU, or antimicrobial usage, in daily defined doses, DDDs. And after computing this antimicrobial usage, let's say at the country level and across different categories or units or even antibiotic types, we computed after that the volume weighted prices per DDD. Again, across different units of analysis, including countries, antibiotic combinations, but also across our categories. So one of the main targets of our paper was to calculate, well, first of all, what's the antimicrobial usage in DDDs across our categories, so for access, watch, and reserve, and also what would be the volume-weighted price per DDD for access antibiotics, for example, across different countries, and the same for watch. Something important here is that most of the prices were reported, I mean, all the prices were reported in international dollars. So basically, we adjusted them by purchase power parity using the World Bank database. As I said before, so we had different units of analysis, including countries, WHO regions, income groups, and also had different analytical groups, including, of course, there were categories, route of administration. So some of the antibiotics were oral antibiotics, some others were parenteral antibiotics, and so on. And also we explored differences across the antibiotic names or types, let's say, such as amoxicillin, for example, or ceftriaxone and others. Well, this is the overall calculation, but in the data set, basically, we had, well, different data inputs across the pack size, for example, of the antibiotics, strength, and total quantity of packs sold. Then we used the WHO daily defined doses, DDT conversions, in order to adjust them to daily defined doses. And basically, at the very end, we had the ex-manufacturer prices, as I said before, for the 2 different sectors, as I mentioned, and then we divided that by the total number of DDDs in order to have a price per volume-weighted price per DDD. Most of the calculations that you're going to see here are referring to the median or interquartile range. And yeah, that's it for now. Also, as part of the methods, and most importantly, because we were looking into the United Nations General Assembly access targets, so basically after calculating the prices per DDD across different AWaRe groups, we wanted to, well, first calculate the percentage of AMU per AWaRe categories. So if we say, for example, that a country has a 50% access use, let's say, as a total volume of usage in the country, so then we wanted to say, okay, what's going to happen if they increase this 50% access share to 70%, and how that could potentially impact cost savings basically at the country level if we replace watch antibiotics by access antibiotics. So this is an important assumption here, because we are replacing, well, watch by access, which could be feasible in some countries, but in some others it cannot. The assumption underpinning this is basically that they comprise the similar molecules because they are mostly beta-lactams. So then at the manufacturer level, let's say, producing them could be even, you know, having the same or very similar cost. yeah, so that was the main goal, as I said, to look into the cost savings, what could happen if we increase this accessory share to 70%, compliant then with United Nations General Assembly targets. But also we looked into other things because given we had the prices per DDDs across different antibiotics, across the AWaRe groups, we also estimated the cost and affordability for single agent treatments for most common oral and parenteral antibiotics. When I say oral, basically I refer to most common treatment at the primary care level and across different infection syndromes. So for example, we have got in there amoxicillin, so let's say 5 days of amoxicillin, and what's going to be the cost of that across different country settings. But also something important here is that we took the case of very expensive antibiotics, such as, watch and reserve type of antibiotics, including meropenem and colistin, and we calculated the prices of a 7-day treatment of meropenem, parenteral antibiotic, and also colistin, parenteral antibiotic for a 7-day treatment course across different countries. And after doing that, we calculated using a relatively novel method. So we calculated the risk of impoverishment from out-of-pocket expenditure only in LMICs if they had to pay for this 7-day treatment courses, out of pocket, as I said. And what would be basically, the percentage of the population in these LMICs that could fall below the poverty line at the country level. So this is what we've done in here using national income distributions and also the Gini to take into account also inequalities across the income distributions. We use here a method that is called generalized beta distribution of the second kind. And of course, we extracted national poverty lines from the World Bank. We are going to look into more details, into that later as I present the results. But then we also looked into the treatment courses for most common antibiotics, as I said before, and most of which are here, oral antibiotics, except for colistin and meropenem, which are parenteral. So an example would be ciprofloxacin, for instance, 500 milligrams for acute bloody diarrhea, and basically every 12 hours for 7 days. And we quantify what would be the price for this treatment in international dollars, and we compare that across countries. All right, so now we can move on to the results. And this is basically what we found. What we found. So we had in here different AWaRe categories. So we have access, watch, and reserve. And this is the median price per DDD, so volume-weighted price per DDD across these different categories. So for an access antibiotic, it's around international dollar, 1.27 international dollars. So varying between 1 to 1.69, let's say 0.69. If we take into account the 25th and the 75th percentile of the distribution. Then for watch antibiotics, if we looked at the median price per DDD in international dollars, that would be 2.76. So basically almost 2 times higher if we compare watch versus access antibiotics, as we can see here. Reserve antibiotics overall per DDD were much higher, almost reaching 100 international dollars, so a bit below that. There were differences across regions and also income groups, and we are going to look into that here now. So for example, if we looked into the access antibiotics, volume-weighted prices, basically, we have that the highest prices were in the Eastern Mediterranean region overall, and then the lowest prices were in Southeast Asia region. Well, potentially linked to actually having loads of manufacturers here, particularly in the case of Bangladesh, India, and so on. For watch antibiotics, so dynamics were, well, relatively similar. So basically, highest and lowest prices were found across, if we just looked into the medians of that, so were found among the same regions. But then when it came to reserve antibiotics, so dynamics were a bit different. Not for the having the lowest prices, but when it came to having the highest prices, we found that in the Africa region, prices were relatively higher for this particular group. And something important, just to refer it here, but we are going to look into that later as well, is that particularly in Africa, many of the reserve antibiotics do not pertain to the essential medicine list, and that's why this basically pushes prices to be a bit even higher. And then when it came to income distributions, as I said before, we didn't have a good representation of low income groups, but only for middle income groups, including upper middle income and lower middle income. So in here, we looked into these different groups, so basically high income countries, and LMICs, which is basically comprising middle income countries, either upper or lower. But we found in here that for access antibiotics, so the median prices were a bit higher compared to high income countries. The same happened with watch antibiotics, but then with reserve antibiotics, was the other way around. This is just given by the fact that in high-income countries, even including in Europe, there is much more reserve antibiotics, such as even cefiderocol, which is not even available in middle-income countries. So basically pushing this price distribution a bit higher compared to middle-income ones. In here, we have got the median prices using this type of graphs, let's say lollipop graphs. We have got the median prices across countries. So that's what you see on the y-axis. So the abbreviation of the country name. And we have got two different rows here. So for the first panel, we basically have those countries having a price that is above the median price for each of the AWaRe categories. And then in second panel or second row, let's say, we're going to have those prices that were below the median price for their respective AWaRe groups. So if we focus on the sub-panel A, we have got access antibiotics here, and we found it consistently that Croatia basically was among the countries with the highest prices. But let's just remember that we are using here international dollars. So basically, we adjusted by PPP or purchase power parity. So if we looked into access and watch, we might see that Croatia and the Philippines were among the countries with the highest overall DDT prices in these categories, and also even for reserve antibiotics. But then when it came to the second, let's say, row or the second sub-panels, let's say, so D, E, and F, we found something different, of course. So then in these cases, New Zealand, for example, was always among the countries with the lowest prices, median prices per DDT across access, and also even watch antibiotics. Yeah, also we wanted to analyze the distribution of these prices, particularly for those antibiotics pertaining to the essential medicine list, so basically and potentially most important antibiotics. And we wanted to look into the distribution of these prices across high-income countries and low-middle-income countries. And as I said before, this LMIC group is basically comprising only middle-income countries, no low-income countries basically there. And then we see that basically most of the distribution kind of overlap with each other, except for some examples such as oxacillin, which is much more, well, expensive overall, let's say, in high-income countries, as we can see it in here. And then the same case stands for ampicillin here. But then when it came to watch antibiotics, again, distributions were relatively similar. but not for reserve, as we might see here. So linezolid, for instance, in high incomes was a bit higher compared to LMICs, but then daptomycin was, on the contrary, a bit higher in LMICs compared to high-income countries, and the same for colistin and others. So clearly there is, well, different dynamics depending on the actual antibiotic we are looking at, and also by our categories. All right. Okay, that's in here. And from the data set, UNGA-AMR, as I said before, we looked into the antibiotic volumes by our categories. So basically the chairs, right? And then in here, we have all the countries on the x-axis coming from Japan to New Zealand. We have gotten these dashed lines, different targets. So for example, the United Nations General Assembly set the 70% target, but the previous target was set at 60% for access and consumption in regard to the total volume per country, right? And well, this figure is basically telling us that in some countries, such as New Zealand, they were already even complying with the 60% target defined previously by the WHO, but they also comply with a 70% target recently defined by the United Nations General Assembly. We observe here that there is also some other countries, primarily coming from Africa, whereby they have a high access usage, that they already basically comply with these targets, because most of the antibiotics they use are actually access type of antibiotics. We also draw a line here for the 80%, but basically we're not going to refer to that now here. Okay, so in terms of the average, let's say, across volume chairs, access antibiotics had a median percentage of total AMU of 50%. It was highest in Africa, 74%, and lowest in Southeast Asia with 36%, being Japan among the worst performing countries, let's say, because they use loads of watch antibiotics, as you can see in here. So the watch AMU share had a median of 46%, and reserve was even less than 1%. So after taking this graph, let's say, into account, we only took those countries having an access percentage below the 70%. So basically countries, let's say, from here to the left, and we replace watch antibiotics by access antibiotics in order to make them to comply with a 70% access volume. And after doing that, basically, and doing this exercise, we realized that countries, if they do it, could save on average 1.6 international dollars per capita, but only, as I said, among eligible countries. So we cannot do it among New Zealand, for example, whereby we find that their access usage is even higher than 70% already. The highest savings were found in Saudi Arabia, Italy, Korea, and Puerto Rico, having basically values between 4.5 and 5.1 international dollars per capita. Well, if we take into account all the sample countries, so the countries we had from the data set, and those that are only actually eligible for replacing watch by access antibiotics, well, this is further translated into an average of 162 millions per country of cost savings, with China basically leading the way at almost 5 billions of international dollars as cost savings if they were able to replace watch antibiotics by access and reaching the 70% access target defined by the United Nations General Assembly. Well, as I said before, not all countries could replace watch by access antibiotics to comply with this target. So these are the cases of New Zealand, as I said before. Let's look into this graph, because they had already an access consumption that was much higher to the 70% target. So those were not eligible for this cost savings type of exercise. But also there were some other countries, and I'm going to just guide you through this graph in here, that had an access to watch price ratio above basically 1. Basically, basically meaning that in countries such as Ecuador, Venezuela, or Japan even, so the prices, the volume-weighted prices per DDT for watch antibiotics were even lower than access antibiotics. So basically, access are more expensive compared to watch. So in those cases, we cannot evidence any potential cost savings by replacing watch by access antibiotics to comply with the 70% access targets. So those countries particularly were excluded from this exercise that we just conducted. Okay, also another important thing, and as I referred to this before, is that, well, countries have different antibiotics. So different antibiotics are consumed in the countries, and some of which pertain to the essential medicine list, but some others do not pertain to the essential medicine list. And basically what we found here is that 93% of the access antibiotics pertain to the essential medicine list, and 70% of watch antibiotics pertain to the essential medicine list, which is also, well, the same percentage for reserve antibiotics. Particularly for high incomes, they had a lower percentage of AML listed watch and reserve antibiotics at 69 and 63% respectively, and compared to low middle income and upper middle income countries. Also, something important is that the median prices were different when we were comparing EML listed antibiotics versus non-EML listed antibiotics. And we even faced, well, a massive variation across access antibiotics, even by 123%, for example. But then for watch antibiotics, this was relatively more stable. And then for reserve antibiotics, we found a price difference of about 54% for EML listed versus non-EML listed antibiotics across the full sample of the analysis. This is also another important, well, let's say, figure. I'm not gonna talk much about it, but basically, depending on the country, we have got countries on the x-axis. They've got different types of antibiotics sold, and in cases like Japan or China, for example, they even have more than around more than 100 or more than 80, let's say, antibiotics sold in the market, which of course adds more complexity, and potentially prices are going to be different because of that as well. And some of which even do not pertain to the essential medicine list, as we see there's differences across the green colors, for example. So being the dark green for access not EML, and then the light green for access being listed in the essential medicine list. So we observe differences for access, but also for watch antibiotics here. All right, so as I said before, we also calculated the prices for most common infections at the primary care level. For example, we have in here acute pharyngitis or acute otitis, for example. And this is the treatment, so 500 milligrams every 8 hours for 5 days. And the median volume-weighted price for this would be 5 international dollars, so coming from 3.6 to 6.5 international dollars across the whole distribution of our countries. Then for other countries, the prices were a bit higher. For example, for amoxiclav, which was around, well, the median price for the treatment course of 5 days was around 14 international dollars, coming from 8 to 22 international dollars if we take into account the 25th and the 75th percentile of the distributions. Well, importantly to say is that for some antibiotics, well, prices, the treatment course for prices were a bit cheaper, of course, but then for others it was much higher. For example, for an oral treatment of linezolid in primary care for mild to severe bacterial infections, so 600 milligrams every 12 hours for 10 days, this was around 780 international dollars, with huge variability, as we can see, that is in here highlighted by the interquartile range. All right, but then, as I said before, so we had the hypothesis that we had 4 different treatments using parenteral antibiotics in the hospital. So before we were looking into antibiotic treatment courses at the primary care level, so basically oral antibiotics, but now we're looking into 4 different groups or 4 different antibiotic courses, let's say, that are administered in the hospital, and therefore they are parenteral antibiotics. What we found here, and after using the models I introduced before, using beta distribution of the second kind type of models, so we found that for meropenem particularly and colistin, the treatments were particularly higher, particularly in LMICs, so around 1,500 and around 1,000 for meropenem and colistin respectively, and that was much higher compared to high-income countries, whereby we found it to be 700 and 500 international dollars respectively. We are talking here about a 7-day treatment course for this type of antibiotics. So after identifying the price for a 7-day treatment course, particularly for this antibiotic, so what we did was to take the middle-income countries we had in our sample only. So we don't see any high-income country here, for example, on the y-axis in this graph. And then we calculated the percentage of the population that could be at risk of falling below the poverty line in each of these middle-income countries. And primarily across meropenem and colistin, but also across other antibiotics, including piptas and ceftriaxone plus amikacin. So what we found here, and after employing these models, was to basically if people are to pay out of pocket for meropenem and colistin course treatment, they are at a significant risk of impoverishment in these countries, particularly in Philippines, with 28% of the population potentially at risk of falling below the poverty line if they need to pay out of pocket for meropenem treatment. And then in Pakistan, on the other hand, it was 21% of the population that could be at risk of falling below the poverty line if paying again for a 7-day treatment course of meropenem. We also found that, after taking into account all the countries we had in our sample, an estimated 437 million of people in these middle-income countries could be at risk of facing impoverishment from out-of-pocket expenditure for meropenem-based treatments. In here, we hypothesized that it was a sepsis treatment, basically having an unknown sort of like pathogen, underlying pathogen causing the infection. We found higher risk in Argentina, Brazil, Bangladesh, India, and China, primarily leading the way in terms of absolute numbers. All right, so now we're approaching the implications and also conclusions of this study. So basically, access antibiotics are overall cheaper than watch antibiotics. Also, there is some price disparities and potentially having the middle-income countries with facing basically higher prices for both access and watch. There were, on the other hand, some countries among the high-income groups, such as, Croatia, having high prices, and we hypothesize that this is primarily driven by low generic use and also fragmented procurement systems. Also for, in LMICs particularly, or middle-income countries, let's say, if they need to pay out of pocket for meropenem or colistin 7-day treatment courses, they could face higher risks of falling below the poverty line. So this is something that we need to take into account, and potentially meeting the UNGA 70% access target could even help alleviate these financial burdens. Finally, well, some LMICs use more expensive non-AML listed antibiotics, which of course hinders progress towards universal health coverage, and therefore also pushing the average prices across our categories a bit higher because of having this type of antibiotics. Well, finally, I just wanted to say that this is a collaboration between, well, several organizations. And yeah, I just wanted to thank also to all the co-authors, including Professor Mike Charland and Kun Powell, based at the City St. George's University and the University of Oxford, respectively. Thank you.